Welcome, everyone. This is Dr. Sharad Jaitly from New York, your cardiologist on your favorite website, MuniMeterHealth.com, which is dedicated to educating you about the human heart and its illnesses, and also enhancing the clinical outcomes by combining the medical education with patient education across the globe. So once again, thank you for joining us and associating with us on MuniMeter Health, your favorite website. We thank you for your enthusiastic support and tremendously growing interest across the globe that you have shown, and we welcome all our medical fraternity and general community at large. Thanks again. Without any further ado, I'd like to delve into the matter of the subject, and the subject of the matter today is pericarditis. What is pericarditis? Now, by now, you should know that whenever I say itis implies inflammation, right? So pericarditis means essentially it's a condition where there is inflammation of the pericardium, which is the outer covering of the heart. Now, the human body is such that every single organ is literally protected by its own covering. Imagine that, now here's my schematic. Now this is the heart, obviously. Externally, this is what it looks like. And so you have a covering which is outside. It has a small layer which is called the visceral layer of the pericardium. Now that hugs almost to the if you will, to the myocardium. And then there's another layer which I'm going to show it with another different color, but it's also adherent right next to it. So if you will, and it just adheres right next to it. I'm trying to draw it here again, it just sort of separates once in a while, but just remember that so it's a two-layered pericardium, if you will, or two-layered capsule outside of the heart, which normally carries about less than 50 cc's of fluid for lubrication. So this way the heart normally functions and is well protected by the other structures within the chest. So the whole idea is wanting to see that nature has given you this pericardial the pericardial covering and a pericardial space in between. Now, normally, as I said, there's about 50 cc's of fluid which is spread all around the heart, so it gives a nice lubrication for the heart. Now, once the inflammation occurs, we'll go into the details as to what causes inflammation in this setting, numerous causes, but once the inflammation occurs, the visceral layer will start secreting some fluid, and so will the parietal layer. And as a result, some fluid will accumulate. However, only a handful of cases, like maybe about 50 to 60% of the cases, only can show up some effusion if you were to do an echo, and we'll get to that in a second. But just so that you know, the fluid accumulates within the visceral and parietal layer. And because there's some inflammation, this will result into a rub because heart is constantly contracting and relaxing. As a result, what happens is there is friction of these two layers, and that causes tremendous pain. So the friction rub, the chest pain, and the fluid collection, obviously, around the heart, these are very, very pathognomic of your of the diagnosis. So when I say diagnosis, normally is achieved by one, chest pain. The chest pain characteristic is very, very sharp. Remember, it's not like your cardiac coronary pain where it's pressure-like. It's more central retrosternal. This is more towards precardium, more towards the left side of the heart, left side of the chest rather. So it is in the left side of the chest. It's over the precardium, sharp, and it has a pleuritic character. In other words, if a person takes a deep breath in and out or leans forward, etc., the pain will be accentuated. So it has a pleuritic character, and that's why. And it's continuous. It lasts 24 hours continuously till the patient seeks help. So that's the characteristic of the chest pain. The second part for the diagnosis is the pericardial rub, if you will. So in order to diagnose, you have to make sure that there is a rub there. And if you hear the rub, that's pathognomonic of the entire findings. All you need is one here. So if you have a pericardial rub, now pericardial rub has three components. Sometimes only two components may be present. One is because of the atrial systole, second is because of the ventricular systole, and the third is because of the ventricular filling. So it has three components to it, and you can hear the three components in a friction rub like. So in addition to the heart sounds, one can hear all these pericardial rubs, and it's like if you if you roll up a couple of my professor in medical school always used to say, if you roll up a couple of hair bands around your ear and try to make some noise by just rubbing it in front of the ear, that's the characteristic of the pericardial rub that you'll hear through the stethoscope, if you will. So that's for the medical students and of course clinicians, so they wanted to just hear what the simulation of the rub is like. The third part, obviously, as I said, is the EKG portion. So the EKG will clearly define the characteristic ST segment elevations, but with an upward concavity. So what do I understand by when I say that? So basically it'll look like the following. I'll draw it with a different color here. Here is your P, the R is slightly depressed, and then your Q, and then you have a T wave like that. So remember that this is the portion which is the ST segment elevation, and it has an upward concavity. And this is your PR, which is depressed. So EKG has two criteria. One is ST elevation, and the second is the PR depression. And this will be all diffuse, by the way. It's not related to just one particular leads. So it'll be diffuse and it'll be present everywhere, just so that we know. So that's very, very important for us. Except in two leads where you will not see the PR depression. There are only two leads, and that's a magic question they always ask you on your boards, if you will. One is V1 and the other is the AVR. So it's not present on V1 and it's not present in AVR, the PR depression. Everywhere else you shall see. So this is your pericarditis in a nutshell as to how it presents. Now let's go to the etiology of what is etiology, and then we'll understand what the diagnosis is then, obviously. So I've defined the pathogenesis and how it's diagnosed, and what are the three criteria to diagnose it. Now etiology, implying that what are the causes of pericarditis? Well, most common is idiopathic, where you don't know the cause. How about that, right? So almost 40% of the cases with conventional testings, unless you really are doing the viral cultures and autoimmune cultures, and then perhaps you may be able to diagnose more thoroughly. But idiopathic with conventional testings will be about 40%. So that's a big chunk. Almost half the cases you'll not be able to diagnose and call it idiopathic now. But don't be discouraged. Then comes the viral. Now that's a big group. Almost 20% of these patients have viral, and you can demonstrate that by Coxsackie titers if you want to do, or you want to do the adenovirus titers or enterovirus titers, viral titers. So these are various titers you will do, and they will be all showing some serial elevation and then defervescence. So there will be a prognostic and diagnostic, both curves you can see when you do these titers, and they can be doing on a weekly basis. Most of the times these are done in clinical trials, or where your large number of cases where you're being seen, especially in an endemic area or there is an epidemic, etc., etc. So viral. Then next very important one is the bacterial. And bacterial, let's take the three groups together: the bacterial, the uremic. So it's easier for you to remember. Uremic, that means in the chronic renal failure settings. And then you have the third variety, which is the neoplasia. Do not forget, it's a very, very important entity. And the neoplasms are obviously the lung, lymphomas, melanomas, leukemias, breast. They like to go to the pericardium. So these are some of the tumors that are commonly seen. Now remember, here's the rule of 7% each. So 7% will be the incidence in bacterial, 7% will be the incidence in uremic, and 7% will be the incidence in neoplasia as well. And then you have other groups where you have autoimmune, which is very, very high ranking. Here scores, remember, SLE. Almost 40% of the lupus in their lifetime, lupus cases will have pericardial manifestations one time or the other. So remember that. Regardless whether they're in remissions or in relapses, but lupus in long course, if you were to just follow 100 cases, 40% of them, they will have one way or the other an autoimmune pericarditis manifestation. Rheumatoid is very important, and then other mixed collagen vascular diseases can be present. These are the autoimmune varieties. Next, where you should consider the etiology is trauma. It could be blunt trauma, especially after an accident or chest injury. And normally it is accompanied by effusion and pericardial tamponade, if you will. And again, you have to. Aortic dissection is a very, very important entity. Unfortunately, it is accompanied by cardiac tamponade, and that is an entity which we'll discuss on a different video because it deserves a full subject as is. But cardiac tamponade is a life-threatening condition, and therefore that needs an immediate attention, and patient has to be hospitalized, and then has to be brought to the OR with pericardiocentesis emergently. But the diagnosis has to be done rather very, very quick. And so that's so specifically so if the pericarditis patients, they develop hypotension, cardiac tamponade should be suspected. Pericarditis patients develop rather more acutely accumulating effusions, cardiac tamponade should be suspected, etc., etc. So remember, the cardiac tamponades can occur everywhere, and specifically so in the neoplasia variety, in the blunt variety where the blunt trauma is there, aortic dissection. So this is where you'll suspect. Do not forget, in the viral, I did not mention about HIV, but that deserves a specific mention. And then in the bacterial, Mycobacterium tuberculosis. So MTB is very, very important here, and HIV is also very important. So you have to order specific testings. For TB, obviously, you're going to use tuberculin tests in the high-risk populations, and HIV, likewise, you'll do the HIV titers or HIV testings when you suspect in the high-risk population. Okay, so having defined that, now let's move on to our next page, which will, without any further ado, define what the like I showed you, how the EKG will look like. For instance, here's a PR depression, and then you have an upward concavity here with an ST elevation. This is an ST elevation right here. So that's your ST elevation, and this is your PR, if you will, which is depressed, and your ST is elevated. So that's your EKG finding. What testings will you order? Now, very importantly, obviously, you've done your ECG. I just told you what the features are. They're diffuse changes like this throughout the leads, except in AVR and V1, where you not see the PR depression. Just remember that. That'll be on the boards one way or the other. They might just show you a clip of EKG which shows PR depression. That's the clinchers there. Just remember that. Or sometimes together, very subtle ST elevations will be present, but the upward concavity is the key. Remember, in myocardial infarction, it's the upward convexity. So that's a distinguishing feature. There, if you were to do there's no PR depression, or very rarely one sees, but you'll see like this. You see the upward concavity here, as opposed to upward concavity here. So these are distinguishing features. This is pericarditis, and this is your myocardial infarction, okay? So upward convexity is the clincher here for the myocardial infarction. Both will have ST elevations, but nevertheless, just seeing the changes will define. So ECG, obviously, the next thing is you want to do is echo. Chest X-ray is routinely done, but to exclude other causes. Not really, you can't confirm pericarditis by a chest X-ray. Maybe in effusion you can see because the heart will look bigger, the cardiac silhouette will look bigger. It used to be like a norm. We used to do the chest X-ray then, but with the advent of echoes in the past 3 decades, I think echo is the clincher. But echo does not show pericarditis. What it will show is, in 60% of the cases, really will show effusion. So there will be pericardial effusion present, and that may be one of the clinchers but absence of effusion does not exclude pericarditis. But pericardial effusion, if it's present, that further supports the diagnosis. That's all I would say. Then you can do other serological studies. Serological studies implying you could do titers, like I said, and you could do immunoassays, or you could do HIV testing and mycobacterial TB testings, etc. can be sent. If there's an effusion, you can tap and send for cultures and bacterial as well as viral cultures. Very rarely you'll see a fungal, I would say, a fungal infection, but that's normally in immunocompromised individuals, not in otherwise. You'll see only in immunocompromised individuals where fungal infections can occur. Like somebody's on post-transplant therapy, like AZT and cyclosporin, steroids, etc. are being given, and a fungal infection can occur. So fungal could be a etiology also, I forgot to mention, within the etiology of the pericarditis. Serological studies, as I said, chest X-ray, echo, ECG. So these are your major testings that you'll perform, and you should be able to diagnose based on these, and of course by clinical acumen. Let's move on to the next page where we'll define what the treatment plan can be. The management is really consistent with the following. One, first of all, you have to relieve the pain and the inflammation together. Remember, it's the pain and inflammation which is excruciatingly bringing this patient over to the ER or to the medical clinics. So the number one drug of choice is the NSAIDs. You have to use anti-inflammatories. So NSAIDs are the best, and you can use ibuprofen, and ibuprofen is wonderful, and one can use that. But a higher dose have to be given, 600 mg to 800 mg, Q8 hourly is the way to go. Aspirin, high dose you can use, and aspirin is preferred more so in a setting where there is an acute MI. By the way, in the etiology, I forgot to mention, I wanted to cover post-Dressler syndrome, which is post-MI pericarditis. This is Dressler syndrome. And then there is also a pericardiotomy syndrome, which occurs after an open heart surgery. So pericardiotomy, once the pericardium has been opened, remember, the patient goes for CABG, and when these patients go for CABG or valve replacements, etc. So there's some inflammation that may be left behind, and pericardiotomy syndrome can be also elicited. This normally occurs after 1 week after surgery. Dressler syndrome occurs like within a couple of days of post-MI. So remember, after MI, one can have Dressler syndrome, which is post-pericardium, post-MI pericarditis. So having said that, aspirin should be preferred in a setting where there's an AMI. If there's an acute MI, use Dresslers. In a Dressler setting, use an aspirin. But otherwise, NSAIDs with high dose, you can increase the dose if the patient does not respond very well within the first 24 hours, just so that you remember. Colchicine is another group of drugs, colchicine-like drugs, and 0.6 milligrams of colchicine twice a day, maybe 2 to 3 times a day, depending upon the patient's body weight, in the first couple of days, and then tapering it down to maintenance of 0.6 milligrams per day should suffice. And there's a maintenance on this. You may continue using this for about a couple of months, at least say 2 to 3 months, because recurrent pericarditis is an issue. Remember, recurrent pericarditis can occur in 40% of these cases. All these cases, they can have recurrent. And the only way to treat recurrent pericarditis is by giving colchicine. So colchicine, if one just starts 0.6 milligrams 2 or 3 times a day in the first 2 days, and then after that on a maintenance for 2 to 3 months, will prevent the recurrence episodes. So this is very, very good drug in that regard. And specifically so, it should be used where NSAIDs cannot be used or aspirin cannot be used, either because there's a contraindication, like a GI bleed is suspected, or patients are allergic to these drugs. Therefore, colchicine really comes out a very important winner there. The fourth group of drugs, do not forget, is steroids. And corticosteroids have had their role because they are the anti-inflammatory of all groups anyway, and they can be applied anywhere. But just remember that steroids should not be used in a setting of acute MI. If you're suspecting an acute MI, do not use it, because it will lead into developing an LV aneurysms or rupture. So that could be real fatal. So remember that in acute myocardial infarction, you want to have the myocardial infarction healed with aspirin or whatever other drugs, but do not use steroids there, please. So that's one of the recommendations that I strongly say. Other than that, the steroids, they're indicated where NSAIDs and aspirins and colchicine cannot be used, or in refractory. So steroids is the fourth line of therapy, really. It's really the fourth line of drug therapy. But you want to use steroids only when you do not have any other access to treat acute pericarditis, like NSAID, aspirin, colchicine have all been used, and there's a refractory pericarditis, we call it, where it's not responding. Then you may use steroids, and again, it has to be slowly tapered. You start with 60 milligrams of prednisone, and then gradually taper it down by 5 to 10 milligrams per week, and so on and so forth, till it's down to 20 milligrams, and then maintain it for several weeks, 4 to 8 weeks, etc., and then taper it down further and take the patient off. So steroids just have its own problems: weight gain, fluid retention, and definitely a contraindication in the setting of acute MI. Okay, so this was in a nutshell the pathogenesis, the etiology, the definition, and the diagnosis, and of course the management of acute pericarditis. I think I've covered enough within this video scope, if you will, and looking forward to talk to you again on my next video. This is Dr. Sharad Jaitly from New York on MuniMeterHealth, your favorite website. Thank you again. So